Hi, I'm Dr. David Rubin from the University of Chicago. This is Best of the Day from the American College of Gastroenterology meeting, which was held in Orlando from Friday, October 13th through Wednesday, October 18th, 2017. This was a special meeting because it was in conjunction with the World Congress of Gastroenterology. Joining me for a discussion of the best of in IBD is Dr. Russell Cohen, who's professor of medicine at the University of Chicago with me and also the director of our Inflammatory Bowel Disease Center. Hi, Russ.
Hi, Dave.
So how's the meeting been going for you?
Well, I think the meeting's been really terrific. There's a fantastic opportunity to see a lot of the young researchers and some of the exciting things that are happening in our field.
There's a lot for us to talk about, so I'm glad that we've discussed a little bit of an outline here. We have a few new therapies to be thinking about in inflammatory bowel disease. One that's been around for a few years now, but we're still learning about, is Vitalysm. We also have the newer therapy that was approved for Crohn's last year, ustekinumab, and some other ones that we're looking forward to. So what did you see at this meeting that was of interest to you in those?
Well, starting with the Vitalysm, as you mentioned, our former IBD fellow, Andres Yarer, was first author on a poster that looked at Vitalysm use in patients with both Crohn's and ulcerative colitis. And what they looked at in particular is whether the drug levels of Vitalysm predicted success or outcomes. And they did show that patients who had higher levels of Vitalysm at week 2, if their level was at least 24, and at week 6, if it was at least 10.8, they actually had better results than patients with lower levels. Now, that's not surprising. We've seen that with other agents, too.
That's right. Anti-TNF drugs.
Anti-TNF drugs, and in fact, all the biologics, I think, have shown that. But one thing that's interesting, too, is that they did show at some of their time points a benefit of being on combination therapy with immunomodulators. And many of us think, well, that's because of antibodies, but in reality, there were very few antibodies seen in any patients, and they were usually transient and disappeared anyway. So we're again faced with this little perplexing issue that patients who have combination therapy, even with Vitalysm, seem to have slightly higher drug levels, which may be important, particularly if they've failed other therapies.
So their drug levels were higher. Were their clinical responses and remission rates higher?
So yes, the patients who had the higher drug levels had higher clinical response and remission rates, and also those patients were more likely to have higher albumin levels too.
So that might be another clue to what's going on there.
Certainly might be a clue, exactly.
So for the viewers out there, would you start recommending doing proactive post-loading Vitalysm levels?
Well, I think that at least in the United States, one of the limits has been whether that'll be covered by insurance, because the levels have been rather costly in some cases. But I think that if it is covered with insurance, that with any of the biologics, it would make sense to check a drug level, and then you can actually adjust the drug based on those levels. And we are actually hoping that insurers will pick up on this, because then we might be able to, in a case, let's say, of infliximab, where we have a lot of range of dosing with the IV dosing, we might be able to actually give the patient what they need rather than too much or too little.
Or waiting for them to get sick again.
Or waiting for them to get sick again, exactly.
So just from a practical point of view, how do you adjust your Vito levels?
How do I adjust the Vito drug? Right, so Vitalysm, after getting the week 0, 2, and 6 loading dose, is then given every 2 months, every 8 weeks.
Every 8 weeks.
And typically what we do is the patients who need to get it sooner, we give it every 4 weeks. It seems.
So you don't change the amount, the 300 milligrams, you just change the interval.
Correct. There really is just, you change the interval, and I actually suggest going from every 8 weeks to every 4 weeks and not making up a number in between, because we have good data from previous studies with Vitalysm showing that patients who are failing who responded but then started failing every 8 week are actually, you can get back remission, recapture back with every 4 weeks, roughly a quarter to a third of the patients.
So the field continues to move to being more proactive in assessing drug and disease, frankly. Let's talk about ustekinumab. What caught your eye there?
Sure. So ustekinumab, there actually was a very fascinating poster looking at the results from the Unity 1 and 2 trials, which are the large clinical trials in Crohn's disease with ustekinumab. Unity 1, if you remember, the patients were all TNF failures. And in that study, the patients initially got 1 dose of roughly 6 milligrams per kilogram IV. But the first time point in the study was week 3. So I get questions all the time, how fast does ustekinumab work? Do I have to wait till week 3? So what these researchers did from the trial is looked at the patient diaries, which are filled out daily, and they looked at their stool frequency, abdominal pain, and general well-being, and found very interesting results. Patients especially their abdominal pain, within day two had a benefit versus placebo. And by day 8, all 3 parameters, the abdominal pain, the stool frequency, and the general well-being were better than placebo. So I think that it's helpful to know that within the first week, we're already seeing very positive responses for patients who get that initial loading dose of the ustekinumab.
Well, as you know, at the University of Chicago, we've treated about 150 people with this therapy over the last year. And we've seen this. The IV loading dose, which was converted from that 6 milligrams per kilogram to just 3 different doses based on body weight, can have a quite rapid response in some of our patients. I tell people that that may occur. But how long should you wait if that doesn't occur? Do you wait to the second dose, which is injection, after 8 weeks, or do you wait to the third dose? And when do you decide that the drug is or is not working?
Well, you know, that's a great question. And I think that having this information from the abstract I just reviewed is helpful because it sees that we really should start seeing results within that first few weeks of dosing, if not even the first week too. The clinical trials, the patients got the 1 IV dose and then they started getting their subcutaneous dose 8 weeks later. But as you know, in reality, patients we have who are sick, who aren't responding completely, will often give a week 4 injection in those. Or if they were getting every 8 weeks and started having breakthrough, we would give every 4 weeks. And there's plenty of data to support that. And in fact, the insurers are allowing that in many of the cases that we've provided the clinical trial information.
So same idea, generally pharmacokinetic adjustments to try and capture patients and optimize therapy.
Yes, you know, it's the key is the patients have to be better, and as you know, because you're a big proponent of the treat to target, we really want to show that they're getting better, not just clinically, but perhaps biochemically with decreasing CRP or fecal calprotectin, and even endoscopically and perhaps histologically. So often in patients who are on biologics who don't seem to be responding, one thing we do is first, we always make sure they don't have C. diff, because as you know, everyone has C. diff. But if they don't, sometimes we even look quick with a flex sig scope if they have distal colitis and make sure they don't have CMV as well, too.
Right. And well, at this meeting, we also had a poster from our own practice where we showed that we had some nice responses with ustekinumab in people with perianal disease. So we've been really quite pleased with this therapy in tough patients.
Yes, and that's a good point you brought up because in our poster experience, many of the patients who had perianal disease did have an improvement, and that is a question I get quite often. How fast does it work, and does it work for perianal disease?
Right.
So 2 pluses on that one.
What other therapies caught your eye, or do you want to mention? Tofacitinib is something we've been excited about. Hasn't yet received its regulatory approval, but we're certainly hopeful that's going to happen in the new year. Tell me what you've learned about that therapy.
Well, you know, the tofacitinib is exciting because if it gets approval, which we are hoping will get in ulcerative colitis, will be the first small molecule therapy. It's a JAK inhibitor.
Non-biologic.
It's a non-biologic, so it's an orally dosed. There should not be, or there should be minimal issues of immunogenicity since it's an oral agent. We anticipate the dosing will be twice a day. We anticipate the dosing will be twice that of the rheumatoid arthritis dosing. So in other words, it'll be 10 milligrams twice a day, we believe, for induction, and then we'll see maintenance if it'll be at 5 milligrams twice a day. You know, with tofacitinib and even the other biologics, one of the concerns is reactivation of herpes zoster. There was a poster that looked at zoster in IBD patients, a very interesting one done at the VA. The study looked at 2 cohorts. The first cohort in the large study, the VA study, looked at IBD patients on mesalamine versus controls. So these were not IBD patients on immunosuppressants. And they showed nearly a twice as high rate of herpes zoster in the IBD patients on mesalamine. So what does this mean? You tell your patients that they are immune suppressed. If you have patients say, I don't want to be on immunosuppressants, you already are immune suppressed. Even those who are quote unquote mild enough just to be on mesalamine are immune suppressed. The second thing they looked at is patients who are on the azathioprins, 6-MP methotrexate, the anti-TNFs or combination therapy. And each of those, as you went from one to the next to the third, had higher rates of zoster reactivation.
So let's get back to this somewhat controversial statement you just made, that the IBD patients who are not on immune suppressants have some abnormality of their immune system that leads to a higher zoster rate. Why is that? What's going on?
It's a good question. Why is that the case? The question is, what is going on in IBD? Is there an immune dysregulation? Is it just in the gut? Is it affecting the whole body? Are there other factors that may be involved that we're not quite understanding why these patients will get these events? And this is why it's important when you hear about patients who get infectious infections, either infections or even certain types of cancers, you really have to have a control group to compare whether the rates are truly higher.
It's very interesting. In the vaccine trials, they've usually used 5-ASA treated patients as the comparator to the immune suppressive patients to see for conversion to immunity. So knowing that this group isn't even considered to be the same as a healthy population is a very important observation.
Absolutely. And, we're really hoping that the inactivated zoster vaccine will come out soon. Many of us are holding off on giving our patients on immune modulators and biologics the zoster vaccine because of concerns that the current one is an attenuated live one. Hopefully we'll get the other one out soon, and then we'll be able to immunize. And I would suggest immunizing even younger patients. That was the other thing that this study showed. The younger IBD patients had higher rates of zoster than the older control patients too.
Agree completely, very important. And when that new vaccine comes out, we're going to be trying to use this. And it's not just those people who are over 50, as you very nicely point out.
Absolutely.
What else caught your eye here in regards to safety or in other ways of thinking about access or cost? What else is on your mind?
Well, so there were a few different posters of interest. One was actually, as you mentioned, cost was one that was looking at a large database, the Truven market database, tens of thousands of IBD patients and looking at their costs over the past few years. And what it showed was quite concerning. Costs for patients with Crohn's disease, particularly the very young, I think the first age group is 0 to 11, lifetime $750,000, ulcerative colitis about $350,000. And it was actually higher in these younger patients over time. And it's not just because they're younger and have more time in their life, but these are the sicker patients. And it really brings to the point that we've been trying to make, and I think, Corey Siegel made when he gave his wonderful talk the other day, was that we have known for now almost 10 years that early intervention with effective therapies decreases patients' disease burden, and they do much better, and we're still barely ever using them. We really need to use effective therapy sooner. We talked earlier about Vitalysm. There's no safety risk to Vitalysm unless you're allergic or intolerant to the medicine. Ustekinumab, another new therapy, really has very minimal safety risk. We're hoping tofacitinib has very minimal safety risks. And in reality, the anti-TNF agents, particularly in our country where we don't have very high rates of TB or other infectious diseases, have been extremely safe and certainly much safer than prednisone. Prednisone has been shown in the TREAT registry to be linked to death and serious infections, and yet people seem to give it like water, and it's not truly effective.
Russ, why is this happening? What do you think is the explanation why 10 years after the Lancet study of early combination therapy is better than mono step-up therapy? What has happened in our field, and why haven't our colleagues gotten on board with some of this?
Well, it is frustrating. I think the overdriving issue is cost. However, if you look at analysis that I actually did in infliximab, and in fact, one of my residents, Femi Kassim, presented our poster with Vitalysm, particularly patients who are naive to biologic therapies have decreased utilization of healthcare resources, and subsequently we show decrease in costs compared to patients once they go on to these quote-unquote expensive therapies. Just because a medication costs more doesn't mean that you're going to be spending more on this patient. We don't pay for just the medicine, you pay for the overall care of patients. And by getting therapy to patients, particularly earlier on, we've already mentioned better outcomes. All of the biologics show much better efficacy earlier in disease than later in disease. They're all FDA approved for moderate to severe disease, not just severe disease. And I think we're really being negligent as physicians and other practitioners in holding back therapies because we're afraid of the cost when in reality, the medicines in the right settings have shown to be
I think cost is part of it. I think that the inertia required to overcome with payers to get pre-auths or re-auths and having your staff work on that, having the discussion with a patient who focuses on concerns about safety, some of which may be real, some of which are exaggerated or actually untrue, are challenges. as opposed to just prescribing something that's oral and cheap that they can pick up at the pharmacy and not call you for a few weeks and leave your office alone. And I say that in all sincerity. We have to do a better job educating our colleagues, educating patients, and the message to patients is they should expect more, and they should be better, and they should know the realities of these treatments. So I appreciate your perspective on that and the work that you and FEMI did at this meeting. Anything else you want to share as the best of here?
Well, you know, there was actually another interesting study looking at telemedicine towards patients. So this looked at patients with IBD who then...
So speaking of ways we might change the way patients perceive all this.
Exactly. And what they did is they received educational information by text messaging, either through once or twice a week, or they had the standard, whatever their provider told them when they had their appointments. And they had the patients fill out the Crohn's and colitis knowledge score at baseline at 6 months and at 12 months. And it showed that actually even just sending the patient a message a week through text messaging, providing education improves patient knowledge about their disease. And this was particularly true in patients who had very poor knowledge of the disease too. So sometimes many of us throw our arms up, say, oh God, this patient's never going to realize what's going on. But maybe that's a reason why we should have increased educational efforts. Again, Corey Siegel talks about how it's not just the provider, but the patients who really have to be on board with therapies. And that when you do get patients who are actively involved and interested, they can be a lot more effective in getting the message across.
Well, and of course at our center we do those quarterly group education events, which we think have been quite effective at getting those messages out.
Absolutely. I mean, really terrific feedback from those two.
Well, on the flip side, I'll tell you about a poster we had at this meeting. It took a long time to get this done, but we were trying to look at whether we could develop a better way to help patients with Crohn's disease quit smoking. And we randomized them to the CDC website, which is a static website where they just read materials, to this intervention that was more interactive. And we found that it really didn't make much of a difference in their steps of behavioral willingness to change. So as much as some interventions like the telehealth intervention by Dr. Cross might be helping education, we certainly have other areas that we can develop better ways to do this.
Absolutely. And as you know, the University of Chicago started a smoking cessation clinic, and really I think it would encourage others to try to get that done at their institutions as well too, or if they're in private practice, to really actively try to refer their patients to effective smoking cessation programs.
A good message. Well, with that, I want to thank you for all your insight at this meeting and for summarizing it for all the viewers out there. I'm Dr. David Rubin from the University of Chicago, and joining me has been Dr. Russell Cohen, also from the University of Chicago. This has been Best of the Day from the American College of Gastroenterology meeting, which is in conjunction with the World Congress of Gastroenterology. Thank you.